All right, so I'm going to kind of continue the themes that Dr. Luo started, and it's really interesting. Even though Dr. Luo Caesar and I are partners in the same practice, we actually do things a little bit differently. Um, and I guess that's probably true with lots of things, not just MicroPulse, but there's certainly more than one way to skin a cat. So I'm going to talk about kind of my perspective on some of its utility in macular diseases, particularly around diabetic macular edema and central serous chorioretinopathy, and some of the tips and tricks that I've experienced and developed over the years. And you'll see that some of them are a little bit different than Dr. Luo, and maybe at the end, we'll have a chance to kind of discuss those differences. So with diabetic retinopathy and DME, we know that the risk factors for developing diabetic retinopathy and DME include uncontrolled hyperglycemia. For every 1% increase in the A1C, there's a 50% increase in the risk of diabetic macular edema. How long a patient has had diabetes and whether they have concurrent hypertension as well are all risk factors for patients to develop DR and DME. In the US, the population of patients with diabetic retinopathy is expected to double to about 15 million patients by 2050. Interestingly, and I know we've got a lot of attendees on this panel from all over the world, this doubling rate is holding true all over the world, in basically every country you look at. So the burden is going to be really a global burden. The historic treatment of DME, of course, if you go back a long time ago, was focal laser, and that actually was, good for reducing the risk of vision loss by 50%, but few patients actually gained vision with focal or macular grid laser. And there were certainly complications of it. Obviously, where you put in a thermal burn, the patients get a scotoma. The laser scar can expand, sometimes double or triple in size over 2 years. You can get secondary choroidal neovascularization with associated subretinal hemorrhage, and you can get atrophy in the area where the scar is. So focal laser was largely replaced by anti-VEGF therapy, which offered the promise of significant vision gains, as Dr. Luo and I think probably everybody on this webinar knows. But to achieve these incredible results, this is from the RISE and RIDE study, the patients required monthly injections. And what do we see in the real world? Do patients actually achieve those incredible results? No, they don't, because it turns out that in the real world, we significantly undertreat our patients. There is this incredible burden. And interestingly, in these two studies, approximately 50% of our patients with PDR, the most advanced form of diabetic retinopathy, are actually lost to follow-up kind of in the real world. And it's interesting, I don't think as physicians we're great at following or thinking about our lost to follow-up patients because we only see the patients that are in front of us. We don't see the patients who aren't in front of us, who haven't come back in. So can MicroPulse play a role here? Can we help improve the vision in patients who've lost vision? Can we reduce that injection burden? And can we stabilize the patients with good vision? And I think the answer is yes. Actually, Larry Morse and his colleagues at UC Davis did a really nice retrospective study looking at 19 eyes with DME that were treated with MicroPulse versus ranibizumab or Lucentis. Both groups gained similar visual acuity at all time points, but the MicroPulse group required significantly fewer injections. There were, at the 1 year time point, it was 1.7 injections versus 5.6. And at the study end, it was 2.6 versus 9.3. That was about 18 months on average. So what are some of the kind of key takeaways when I read this paper, and I've seen Dr. Morse present this work before? Number one, MicroPulse was used relatively early in the treatment course. So this wasn't kind of these chronic recalcitrant end-stage diabetic macular edema eyes, MicroPulse was used early in the treatment course, typically when patients had received somewhere between 0 and 3 injections. And I think it works better with milder disease. And Dr. Morse found that as well, that the MicroPulse was more effective when the DME was less than 400 microns. So for that really thick and swollen retina, I think a little bit of induction therapy with anti-VEGF can help. But if you're so end stage where even the anti-VEGF injections or steroids aren't working, and then you say, well, let's try MicroPulse on that patient, I think you'll kind of have an unsatisfying response. Whereas if you use it early in the course of treatment, that's when you can really see a difference and reduce your need for kind of chronic injection therapy. So here was one of the cases from Dr. Morse. I think this is a, pretty significant level of diabetic macular edema, 20/50 vision, given MicroPulse treatment at baseline. And at 12 months, oh, that's funny. At 12 months later, the patient had received 2 Lucentis injections, which I think over a 1-year period, I think we'd all argue and recognize that, hey, that is a great outcome. Significant improvement in the intraretinal fluid and the central macular thickness, and most importantly, the visual acuity improved from 20/50 to 20/25. So great answer, great result there. And I think it really highlights some of the points, and you'll see the same things come up here when I talk about central serous retinopathy. And I'm going to start this one with a case. This is a patient of mine with who'd actually had reduced fluence PDT in 2011 for chronic central serous. The fluid resorbed. His vision was 20/20, but he never felt like his vision really recovered, and he had a scotoma, relative scotoma right below fixation, and reported kind of trouble with his color vision, dyschromatopsia. In 2015, he came to see me. The fluid had recurred and his vision dropped to 24/8. And here you can see the fluid, subfoveal fluid. And this is his scan. And you can see actually like a almost perfect circle where the PDT had been applied back in 2011. And this is really where the patient was complaining, even when the vision was 20/20, about that relative scotoma. Because when we look carefully at the OCT, now this is when he's recurred in 2015 when there's subretinal fluid there, but he really has no photoreceptors left against the external limiting membrane there. So a very poor photoreceptor layer, which is why he had this kind of permanent scotoma from the PDT. So he was adamant he did not want more PDT, and I said, let's try MicroPulse. I did a 200 micron spot size, 400 milliwatts with a 5% duty cycle, and I'll go through my settings at the end. And I applied it confluently to the serous RD. And 2 months later, the fluid had resolved. He was 20/20, very happy. And you can see up above, this is where he'd had PDT previously. There's still like a disruption in his photoreceptor layer. So he's kind of left with a bit of a scotoma from his prior PDT. There was actually a randomized controlled trial that was published in 2015 comparing MicroPulse to half fluence or reduced fluence PDT for chronic central serous. And the results are pretty similar. 24 patients in the half dose versus 20 in the MicroPulse. They gained 8.5 letters versus 6.7 letters. Observation only 1.5 letters. So no statistical difference between PDT and MicroPulse. They actually looked at fluorescein angiography leakage area and showed a pretty similar reduction in the leakage area. And the takeaway from the authors was that MicroPulse was a good option for patients with acute central serous or a shorter time of onset of the disease before the loss of the IS, OS, and visual functions become irreversible. Whereas PDT seems to be a good treatment possibility in the chronic progressive forms. And so again, kind of my insider tip here is MicroPulse is best used early in the disease course, just like we saw with Dr. Morse's patient in diabetic macular edema. So PDT, although some people call it kind of the gold standard for chronic central serous, and oftentimes people will wait on fluid and just see if it goes away on its own. But that fluid can be very disabling. This is a quote from a patient of mine who really struggled afterwards. And I think MicroPulse offers our patients an opportunity for us to intervene early in the disease course before some of these changes become permanent. So some of my tips and tricks, well, just like Dr. Luo said, there is a learning curve. There's definitely a tendency to undertreat at first. You want to go kind of low intensity and high density, so very close spot size. One spot kind of really just immediately adjacent to the next spot. Have patience with it. It's a slow and steady response. It's not a kind of instantaneous. So you don't have that kind of immediate response like you get with an injection, where if you see an injection patient 1 week later, usually the fluid's a lot better. I think MicroPulse works best in early in the course of these fluid maculopathies, or when the fluid's more mild, and it can really be adjunctive in some indications, like Dr. Luo pointed out. One thing I think that's really important is that the focus of your laser beam still matters. So focus still matters for sure. And it's interesting to hear Dr. Luo, even though we're partners in the same practice, he does 7x7 with a Texel pattern. I actually prefer to do one spot at a time. And I feel like that gives me a little bit more control in terms of my placement. Sometimes with the Texel, it can kind of take a moment for all 49 spots to get placed. So I tend to like just doing the individual spots one at a time. And I always confirm that I'm not in continuous wave mode. Dr. Luo had mentioned that as well. And I typically will, it's definitely repeatable. I typically repeat it if it's necessary. About the 3-month point would be the soonest I would do it again. But usually that's not needed. And, I have repeated it as soon as 3 months. So I use a 200 micron spot size with 400 milliwatts, 200 millisecond duration with a 5% duty cycle. I use an ocular Mainster focal grid lens. This has no magnification provided by the lens, so it's truly a 200 micron spot size. And as I was saying, I do single spot. Dr. Luo talked a little bit about the differences between 532 and 577. And maybe there's some theoretical advantages with 577. I use 532. It's what we have in the practice. It's also what I trained on in fellowship. And because we're using it as MicroPulse, we're not getting scarring of the RPE. So there's no, spot size creep where the spot gets larger because we're never putting a spot. This is subvisible MicroPulse laser.